Hi, everybody. I just wanted to start by welcoming you all to this first of a two-part presentation on the GOLD guidelines for the treatment of COPD. Our next part two, will happen next week at the same time, Wednesday. If you have not registered for part two, we are almost at capacity, but just like all of our other webinars, we will have this one and next week's available online within a few days. I just want to start by doing a quick audio check. If a couple of people could just use the thumbs up window to let me know that you can hear us okay, that would be great.
Hello.
Excellent. Wonderful. Good. So we have sound. Oh, I'm hearing some background noise. Not sure if that's coming from Tom or one of our other presenters. Excellent. All right.
It might be coming from me. My apologies. I'm trying to mute my microphone.
Yeah, absolutely. Yes.
Sorry, I had some technical issues. I think everything's ready to go.
Tom, Mark, are you guys able to hear me just before we get going?
Yep, I am.
Okay, great.
Yep,
Sorry
I can hear
about
you
that,
now.
everybody. Great. Sorry about that. So welcome everyone to today's Global Initiative for Chronic Obstructive Lung Disease Part 1 presentation by Dr. Mark Rasmus. We've done the audio check, and it seems like that was good for everybody. Dr. Mark Rasmus is the medical director of the Ohio Sleep Health Center. He's board certified in pediatrics, internal medicine, pulmonary medicine, critical care, and sleep medicine. And Mark's really very dedicated to public and professional education on a number of different issues, including sleep, non-invasive ventilation, and as we see from today's presentation on COPD. We're very fortunate and thankful to have Dr. Rasmus again for a presentation. It seems when we have him present, we always book up to full capacity. So without any further ado, I'm just going to turn things over to Mark. If you notice that you have any questions or you want to ask Mark a question, you should have a question icon at the top of your screen. If you use that, then we'll see your questions as they come in. All right, Mark, take it away.
Sounds good. Thanks for the introduction. I am from Idaho, though, not from Ohio. Idaho's borders Canada in the Rocky Mountains, northern Rocky Mountains. So anyway, today we're here to talk about COPD, and I'm going to do a two-part series introducing and reviewing the GOLD guidelines, which is the Global Initiative for Chronic Obstructive Lung Disease, and these were updated just several months ago. This is a worldwide organization, and as you can see by the board of directors, as well as the following slides, all the docs that participate, this really is an international committee. You have docs from, Western Europe, Japan, Australia, China, United States, Canada, really who's who of pulmonary medicine is involved in formulating these guidelines. And it's important to see that these guidelines are meant for global implementation, and there's some key points that address developing countries as well as developed countries like the United States and Canada. Feel free at any point to interrupt with questions, and I'll be happy to address them as they come in. My talk is sponsored by Sleep Education Partners, sleepedu.org. We have online education for sleep and some respiratory medicine. And you can log on through your organization's portal/hub as well. As far as the website access to the GOLD guidelines, I can't, strongly enough recommend, bookmarking this website. It's awesome. There's news for and information for providers. There's information for patients. You can download the slides that I'm showing you. You can download a PDF of the abbreviated guidelines, and I think they even have a web app that you can install on your phone and kind of go through the guidelines through the app as well. COPD. COPD is currently the 4th leading cause of death in the world. It's projected to be the 3rd leading cause of death by 2020. And it's estimated that over 3 million people died of COPD in 2012, which accounts for 6% of all deaths globally. Globally, the COPD burden is projected to increase as the population gets older, and we have continued exposure to COPD risk factors, particularly cigarette smoking increasing in prevalence in developing countries. So the GOLD objectives are basically to provide a non-biased review of the current evidence for the assessment, diagnosis, and treatment of patients with COPD. We're going to highlight the short and long-term treatment objectives organized into 2 groups. We'd like to relieve and reduce the impact of the symptoms and reduce the risk of adverse health events that may affect the patient in the future. And we're going to guide symptom assessment and health status measurement. As we look through these guidelines, you'll see that evidence is graded or scored by that professional committee that we went through earlier. And the grading is relatively straightforward in the sense that they score A through D, as we might remember from grade school, A being the best grade, D being barely passing. And A is obviously endpoints from well-designed, randomized, controlled trials, and in general, you need to have at least 2 clinical trials to qualify as, A-level evidence. B-level evidence is obviously less conclusive, and then you go down to level D evidence, which is essentially just panel consensus or judgment based on consensus of those that took part in the committee meetings. As mentioned, levels of evidence have been assigned to evidence-based recommendations where appropriate. Anytime there's an evidence level, you'll see it in bold and in parentheses after the relevant statement. Methodological issues concerning the use of the evidence from the meta-analysis were carefully considered. As I mentioned earlier, the A through D grading replaces a prior system that was previously used in earlier GOLD reports. I think it's a little bit more straightforward and simple. So the GOLD report is divided into 6 different chapters. We're going to cover the first 3 today, which includes the definition and overview, the diagnosis and initial assessment, and evidence supporting prevention and maintenance therapy. Next week, we'll talk about management of stable COPD, management of exacerbations, and COPD and its interaction with medical comorbidities. So moving on to the definition and overview, chronic obstructive pulmonary disease is a common, preventable, treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that's due to airflow and/or alveolar abnormalities usually caused by significant exposure to noxious particles or gases. In the developing world, this is predominantly cigarette smoke. Obviously, pollution can play a role. And then when you look at developing countries, they generally have increased risk for cooking over open fires and fossil fuels. And so females in general that are doing the cooking at home are exposed to inhalational injuries related to that, something we don't think of necessarily in the developed world. When we look at the etiology, pathobiology, and pathology of COPD, you can see there's smoking and/or other pollutants that play a role. There's also host factors. Some of us are more predisposed to chronic obstructive pulmonary disease than others, and we'll talk a little bit about that later. And this is associated with pathobiology that involves impaired lung growth when you expose younger children, accelerated decline of lung function in adults, lung injury, and lung as well as systemic inflammation. The pathology shows small airway disorders or abnormalities, generally involving thickening of basement membranes, inflammation. We see emphysema, which is the loss of alveoli in the lungs. And we also see systemic effects of smoking, as is seen in some of the comorbid conditions, most notably cerebrovascular disease and cardiovascular disease. And when we look at patients with these exposures and this pathology, we look to see whether or not there's any persistent airflow limitation. And if they do have airflow limitation, or even if they don't, do they have symptoms related to this, shortness of breath, cough, wheezing, sputum production? Do they have exacerbations where this disease gets worse and then better? And do they have any comorbid conditions? When we look here at this slide, you can look at FEV1 in percent predicted over the maximally obtained value. And you can look at tracing number 1, shows an FEV1, somewhere around 100% in your 20s or 30s, and you see gradual decline as you age. Line number 2 shows somebody with smaller lungs, but no evidence of any COPD. That's the yellow line. So that would be somebody with possibly restrictive pulmonary disease. Line number 3 shows a normal initial FEV1 with a rapid decline, which is commonly seen in cigarette smoke or COPD. And then line number 4 shows somebody that had smaller lungs to begin with, and then had a more rapid decline as compared to the yellow line in tracing number 2. And those patients have COPD as well. So you can see there's several different phenotypes for the same disease. So as far as overall clinical points, chronic obstructive pulmonary disease is a common, preventable, and treatable disease that's characterized by persistent respiratory symptoms and airflow limitation that's due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases, commonly cigarette smoke. The most common respiratory symptoms include dyspnea, cough, and sputum production. These symptoms may be underreported. It's not uncommon at all. You ask a cigarette smoker whether or not they cough every day, and they say, no, I don't cough. And then you can ask the same question, well, do you wake up in the morning and have that smoker's cough to, quote unquote, clean your pipes? And they'll all say, oh, yeah, I clean the pipes early in the morning. So how you ask the question, you might get different answers. The main risk factor for COPD is tobacco smoking, but other environmental exposures such as biomass fuel exposure and air pollution may contribute. The biomass fuel exposure is what I was referring to earlier about developing countries and cooking over an open flame. Besides for exposures, host factors predispose individuals to COPD. These include genetic abnormalities such as alpha-1 antitrypsin deficiency, abnormal lung development, and accelerated aging. COPD may be punctuated by periods of acute worsening of respiratory symptoms, and we refer to these as exacerbations. In most patients, COPD is associated with significant concomitant chronic diseases, which increase its morbidity and mortality. So one thing I always like to interject is that not all cigarette smokers develop lung disease. When I was in medical school, they used to estimate 15% of patients that smoked cigarettes chronically developed lung disease secondary to it. The more recent estimates estimate that between 45 and 50% of chronic cigarette smokers develop lung disease. So certainly not all cigarette smokers are COPDers. So the prevalence of COPD, this is done, there's a systematic review and a meta-analysis done in 2006. This included studies carried out in 28 countries between 1990 and 2004, so the data is now almost 15 years old. And the prevalence of COPD was higher in smokers and ex-smokers compared to non-smokers. It was higher in those greater than 40 years of age as compared to those less than 40 years of age, and it was higher in men as compared to women. The prevalence is estimated to be 384 million people with COPD living in 2010. The estimated global prevalence is estimated to be approximately 12%. And there are 3 million deaths annually from COPD. With increasing prevalence of smoking in developing countries and an aging population in high-income countries, the prevalence of COPD is expected to rise over the next 30 years. By 2030, it's predicted that we'll have 4.5 million COPD-related deaths annually. Pretty impressive in terms of the scope of the problem. As far as the economic burden of COPD, it's associated with significant economic burden. Exacerbations account for the greatest proportion of the total COPD burden. I don't think this is much surprise to any of us. In the U.S., where the managed care environment and pay for performance is becoming a big issue or a buzzword, physicians, hospital groups, insurance plans are really working hard to cut down on emergency room visits for COPD exacerbations and hospital admissions. These are a huge stress on the economics behind our healthcare system. In the European Union, direct costs of respiratory disease are about 6% of the total healthcare budget. COPD accounts for 56% of the costs of respiratory disease on a whole. This is almost 39 billion euros. In the United States, it's estimated that the direct costs of COPD are $32 billion, and the indirect costs are another $20.4 billion. In the Global Burden of Disease study, they looked at something called disability-adjusted life years, or DALY, which is the sum of years lost because of premature mortality and years of life lived with disability, adjusted for the severity of the disability. So COPD is an increasing contributor to disability and mortality around the world. And in 2013, COPD was the 5th leading cause of DALYs lost. In the United States, COPD is the 2nd leading cause of reduced DALYs, trailing only ischemic heart disease. That was shocking to me. I always thought people missed work because of, or became disabled predominantly because of low back pain, because that's what we see in our primary care practices in the U.S., but clearly ischemic heart disease and pulmonary disease lead the way. So what factors influence disease progression? One of them are genetic factors. Some of those of us are more genetically predisposed than others to develop lung disease when exposed to cigarette smoke or environmental causes. Age and gender play a role, lung growth and development, exposure to particles, socioeconomic status, asthma and airway hyperreactivity, chronic bronchitis, and infections. As far as the pathology, in general, we see chronic inflammation related to COPD. Sometimes we'll see increased mucus-secreting glands as well. We also see structural changes, the most impressive of which is emphysema when seen pathologically. You see loss of alveolar walls and loss of alveolar surface area, which provides gas exchange. The pathogenesis of COPD involves oxidative stress, protease and antiprotease imbalance, as we see with alpha-1 antitrypsin deficiency. We see inflammatory cells, we see inflammatory mediators, and then we see both peribronchiolar as well as interstitial fibrosis. Generally, these are more chronic changes after the lungs been exposed to chronic inflammation and repeated damage. The pathophysiology affects airflow limitation and gas trapping. So generally, it's an obstructive pulmonary disease with a difficult time exhaling. Because of that, we also see air trapping, where people cannot expire all the air that they've inhaled. We see gas exchange abnormalities, typically seen in decreased DLCO on pulmonary function testing, where the patient has a difficult time taking oxygen from the air and transferring it to the blood vessels. We see mucus hypersecretion. These patients tend to bring up a lot of clearish, yellowish phlegm. And we can also see pulmonary hypertension, which generally develops once patients have been exposed to chronic hypoxemia. Moving on now, we'll talk about the diagnosis and initial assessment of COPD. COPD should be considered in any patient who has dyspnea, chronic cough or sputum production, and/or a history of exposure to risk factors for the disease. Spirometry is required to make the diagnosis. I can't stress this enough. I'll say it again. Spirometry is required to make the diagnosis. The presence of a post-bronchodilator FEV1 to FVC ratio of less than 70% confirms the presence of persistent airflow limitation. These are the numbers that we use for the global guidelines, and it's a very oversimplified measure. All I will point out at is when you look in developed countries, there's probably more accurate numbers we can use to define obstruction. The NHANES 2 data is probably the most accurate currently, and we recommend when you're reviewing pulmonary function testing to use the lower limit of normal when calculated for a specific patient based on their age, race, sex, and height, rather than just the 0.7. But keeping it simple and sticking to the guidelines, less than 70% is considered obstruction. The goals of COPD assessment are to determine the level of airflow limitation, the impact of the disease on the patient's health status, and the risk of future events such as exacerbations, hospital admissions, or death in order to guide therapy. Concomitant chronic diseases occurring frequently in COPD include cardiovascular disease, skeletal muscle dysfunction, metabolic syndrome, osteoporosis, depression, anxiety, and lung cancer. These comorbidities should be actively sought and treated appropriately when present, as they can influence mortality and hospitalizations independently. So we know of the symptoms. Generally, when you suspect it, you ask about shortness of breath, you ask about chronic cough, you ask about sputum production. Other things you might ask about are weight loss, fevers, chills, hemoptysis. We also assess the risk factors, the host factors of their family history. Do they have any genetic predisposition? Do they have any chronic pulmonary issues that predate this? Are they exposed to tobacco? Any sort of occupational exposures? Are they exposed to indoor, outdoor pollution? And after kind of, assessing these risk factors and symptoms, at that point, if you are concerned enough to look, spirometry is necessary to create the diagnosis. In general, we recommend looking in patients over the age of 40. We worry about dyspnea that's progressive over time, when it's worse with exercise, and when it's persistent. Chronic cough might be intermittent and may be unproductive. They may have a recurring wheeze associated with their cough. And any pattern of chronic sputum production may indicate COPD. So whether it's clear or yellow or green or occasionally specked with blood, it all can be associated with COPD. We assess the risk of recurrent lower respiratory tract infections. Have they been hospitalized for pneumonia? Have they been treated with several courses of antibiotics? We look at a history of risk factors such as genetic factors, congenital or developmental abnormalities, tobacco smoke, including secondhand smoke, smoke from home cooking or heating fuels, occupational dust, vapors, fumes, gases, and I guess you can also include vaping as well. And then we look to see whether or not there's a family history of COPD and or childhood risk factors. Was this a premature child that developed into an adult with chronic respiratory infections, or is this somebody that was full term with no issues until 40 when their smoking caught up with them? We mentioned this also all already, but the symptoms of COPD include chronic and progressive dyspnea and cough, sputum production, wheezing and chest tightness. Other things you might see: fatigue, weight loss, anorexia, syncope, rib fractures, ankle swelling, depression, anxiety. Other causes of chronic cough, so all that causes or all that wheezes is not COPD. So other causes of chronic cough, intrathoracic causes would include asthma, lung cancer, tuberculosis, bronchiectasis, left heart failure, interstitial lung disease, cystic fibrosis, and just an idiopathic cough. As far as extrathoracic causes of a chronic cough, you have allergic rhinitis, postnasal drip, upper airway cough syndrome, GERD, and medications, most notable being ACE inhibitors. Patients' exposure to risk factors is important to note. You know, we always want to note tobacco use in terms of pack years, so how many years the patient smokes times an average of how many packs per year. And then if they quit, how many years ago they quit. We ask about their past medical history. We want to hear about more than just the lung disease. We want to know if there's a family history of COPD or other chronic respiratory disease. What's been the pattern of symptom development? Did this come abruptly, or is this something that developed chronically and progressively over time? We'd like to know about a history of exacerbations or previous hospitalizations for respiratory disorders. Is this a patient that was labeled an asthmatic as a kid and was hospitalized and intubated for it, for example? We want to know about their comorbidities, the impact of the disease on the patient's life. You know, are there things they can't do? Does it affect their work? Does it affect their social life? Does it affect their ability to exercise or recreate? Want to know about any social or family support available to the patient. And we'd like to know about possibilities for reducing risk factors. So smoking cessation is number one. You can imagine in someone that has a partner that smokes, you know, having them smoke outside, or a parent that smokes and children and a child. There's other ways to modify things. So diagnosis and initial assessment, considerations for performing spirometry. So spirometry is the tool used for diagnosing COPD. It's important to realize that it's a very operator-dependent test, and not anyone can just perform spirometry. Spirometers need to be calibrated on a regular basis, generally daily. A lot of them have self-calibration modes. Spirometers should be able to provide a hard copy, either a printout or a digital display of the expiratory curve, so we can detect technical errors, and we can also look and see whether a test is adequate just by looking at it quickly. The supervisor of the test needs training in optimal technique and quality performance, so this needs to be a trained, in general, respiratory therapist. You need maximal patient effort in performing the test. Otherwise, you get underestimation of values and hence errors in diagnosis and management. So the patient's got to be willing to work to get good PFTs. When we do bronchodilation associated with spirometry, there's different protocols as to whether or not you use a beta agonist or a short-acting anticholinergic or the two combined. There's several different protocols. In general, after the medications are inhaled, patients measured 10 or 15 minutes later, or 30 to 45 minutes later, depending upon the medication used. Spirometry should be performed using techniques that meet published standards, and I would recommend looking at the ATS and the ERS for their published standards. The expiratory volume and time tracing should be smooth and free of irregularities. The pause between inspiration and expiration should be less than a second. The recording should go long enough for a volume plateau to be reached, which may take more than 15 seconds and a lot of coaching, I might add. Both FVC and FEV1 should be the largest value obtained from any of 3 technically satisfied curves. And the FEV1 and FVC should vary no more between 5% or 150 ml. So these are things we look at to figure out whether the testing is reproducible and adequate for interpretation. And the FEV1 FVC ratio should be taken from the technically acceptable curve with the largest sum of FVC and FEV1. So we want their best effort. Spirometry measurements are evaluated not only compared to reference values, but these reference values are based on age, height, sex, and race. And when available, you should compare it to previous testing performed by the same patient. And the presence of a post-bronchodilator FEV1 to FVC ratio of less than 70% confirms the presence of airflow limitation. When you look at a normal tracing versus somebody with obstructive disease, obviously you see somebody with obstructive disease takes longer to plateau out, and despite the fact that they're blowing for longer, they can't blow out as much volume, particularly in 1 second. And you look at their ratio, and rather than being a normal 0.8, it's an abnormal 0.56. So this is what you would see in a flow volume or a volume time curve. When we classify the severity of the limitation, we do that just based on the FEV1. So it's important to look at the FEV1 to FVC ratio to define whether or not there's obstruction. And then once you note that there's obstruction, you look at just the FEV1% predicted. And then if it's greater than 80%, they have mild obstruction. 50 to 80%, it's moderate. 30 to 50% severe, and less than 30% predicted, it would be very severe. When we look at symptoms, there's several different symptom questionnaires. There's the COPD assessment test, which is the CAT test. There's the chronic respiratory questionnaire. There's the St. George's respiratory questionnaire. There's the chronic respiratory questionnaire, the CRQ as opposed to the CCQ. And then there's the Modified Medical Research Council questionnaire. And these are all just different questionnaires that are used to assess symptoms. So there's 2 things we're always assessing. We're assessing the FEV1 as well as their symptoms to address the severity. And the reason why we're looking at the severity is we're assessing the exacerbation risk. Remember, I mentioned that the biggest financial burden of COPD is associated with the exacerbations. So one thing we want to do is assess people at high risk for developing exacerbations. Exacerbations are defined as an acute worsening of respiratory symptoms that result in additional therapy. They can be classified, the risk can be mild, in which case you might treat with only short-acting bronchodilators. It might be moderate, which might convince you to treat the patient with short-acting bronchodilators plus antibiotics and/or oral steroids, or else severe, and this would be an exacerbation that requires hospitalization, and these also might be labeled acute respiratory failure. Another thing that might predict exacerbation rates in patients not on an inhaled corticosteroid would be blood eosinophil levels. This is not something generally performed in practice. So kind of this is probably, one of the more important slides on the whole talk, but this is the way we assess patients with COPD. We spirometrically confirm the diagnosis, and we do this with an FEV1 to FVC ratio of less than 0.7. We then assess the degree of airflow limitation, and depending upon this is the percent predicted FEV1. And then we look at the exacerbation history. I want to know if they've had greater than 2 exacerbations or greater than 1 exacerbation leading to a hospitalization, or else 0 to 1 exacerbations with none of them leading to a hospital admission. And then I want to know their symptom scores. And we looked at their symptom scores. I gave you a couple different scoring tools on the previous page, but essentially the people on the left-hand side of that ABCD box are those with less symptoms, and those in the right-hand side of the box have more symptoms. So the patients that are at higher risk for developing exacerbations would be those with more symptoms, as well as those with a higher exacerbation history. So those in box D have the most symptoms and the higher exacerbation history. So those would be highest at risk, whereas those with less symptoms and no history or less of a history of exacerbations in box A would be least likely of developing exacerbations. We'll go back to that tool in the future when we talk about treatment options and treatment algorithms. But just giving you an idea of how we use this ABCD assessment tool, if we were to consider two patients, both with an FEV1 of less than 30% predicted, which puts them in the severe category. Both of them have a CAT score of 18, so they're very symptomatic, but one has 0 exacerbations in the past year and the other one has 3 exacerbations in the past year. Both would have been labeled Gold D in the previous classification scheme, which didn't look at exacerbations. But with the new proposed scheme, subject with 3 exacerbations would be in Gold Group D, whereas the one that had no exacerbations would be Gold Grade 4 Group B, meaning they have lots of obstruction by spirometry, but not much in terms of exacerbations. Answering Ben's questions, why do we use a post-bronchodilator test for diagnosis opposed to no bronchodilator? That is the standard. Essentially, all these patients, when they have their initial spirometry, should be assessed, and spirometry should include pre and post bronchodilator. We want to use the best numbers. That's been the international standard for decades, and that's just the way it is, Ben. Thanks for the question. Summary, so the role of spirometry, it's used for diagnosis, it's used for the assessment of the severity of the airflow obstruction, which we hence will use in prognosis. And we use it to follow up assessment. So therapeutic decisions, we might look at some pharmacological options in selected circumstances, a discrepancy between spirometry and level of symptoms. It might make us consider alternative diagnoses when symptoms are disproportionate to the degree of airflow obstruction. So if someone has really mild airflow obstruction, really severe disease, you might want to consider an echocardiogram or something else to explain the symptoms. And this might also affect non-pharmacological interventions, including interventional procedures, surgeries, interventional bronchoscopy. We'll talk about this in the future. And we also want to assess the degree of decline. Is someone stabilized? Are they declining quickly? Are they having rapid decline? A little case story of this, my dad was a non-smoker, lots of environmental exposures, and has mild COPD. We were following him annually, or actually every 2 years at the time, with spirometry and watching his decline. We started him on Spiriva. This was probably a decade ago, and we were able to note a decrease in the rate of decline of his spirometry, and that was reassuring for all of us, including my dad, who decided to continue to take the medication rather than stop it because he didn't clinically feel better one way or the other. How about alpha-1 antitrypsin deficiency? The World Health Organization recommends that all patients with a diagnosis of COPD should be screened once, especially in areas with high alpha-1 antitrypsin deficiency. And the reason why is we need to figure out the scope of the problem and how many people it truly involves before we can estimate an accurate prevalence and what we need to do as far as treatment. So I think from an epidemiologic perspective, it's very important. From a practical management standpoint, it's not as helpful. Alpha-1 antitrypsin deficiency patients are typically less than 45 years of age when they present with panlobular basal emphysema. So emphysema generally, when associated with tobacco use, affects the upper lungs first, and it's centrilobular emphysema, whereas those with alpha-1 antitrypsin get lower lung zone emphysema, and they get panlobular emphysema. Delay in diagnosis in older alpha-1 antitrypsin disease patients presents as a more typical distribution. So if they've gone with long enough without it, they start to look like a typical smoker. Low concentration, which would be defined as less than 20% the normal level of alpha-1 antitrypsin, is highly suggestive of the homozygous deficiency. So the differential diagnosis of COPD, things that go for COPD, onset in midlife, symptoms that slowly progress, having a history of tobacco smoking or secondhand smoke or another exposure is helpful. Asthma you tend to see earlier in life, typically childhood onset. Symptoms vary a lot from day to day. Symptoms are generally worse at night than they are in the early morning. You might have allergies, rhinitis, and eczema associated with it. There's generally a family history, and obesity may be coexisting with the asthma. As far as patients with congestive heart failure, chest x-ray will show a dilated heart, pulmonary edema. Pulmonary function testing won't necessarily show airflow obstruction, but is more likely to show volume restriction. As far as the DLCO, it might be increased acutely with acute congestive heart failure, but more chronically you see a decreased DLCO. Patients with bronchiectasis tend to bring up large volumes of purulent sputum, commonly associated with bacteria or atypical mycobacterial infection. And chest x-rays and CT scans shows bronchial dilatation and bronchial wall thickening. Tuberculosis, you can have this at any age. Chest x-ray will generally show a lung infiltrate confirmed by microbiology, and generally you'll see a high local prevalence of tuberculosis, or else a history typically in a refugee moving from an area of high prevalence to an area in a developed country where it's less prevalent. Obliterative bronchiolitis, generally seen in younger age non-smokers. They may have a history of rheumatoid arthritis or an acute fume exposure. In general, this is seen after pulmonary or bone marrow transplantation. And the CT scan, at least the high-res CT on expiration, will show hypodense areas, patchy hypodense areas. Diffuse panbronchiolitis, it's predominantly seen in Asians, more common in men and non-smokers. Almost all of these patients have chronic sinusitis, and chest x-ray and HRCT show diffuse small centrilobular nodular opacities and hyperinflation. This is generally a diagnosis made by biopsy. Moving on to our final section for this morning. This is the evidence supporting prevention and maintenance therapy. So overall key points, smoking cessation is key. Pharmacotherapy and nicotine replacement reliably increases long-term smoking abstinence rates. The effectiveness and safety of e-cigarettes as smoking cessation aid is uncertain at the present. Pharmacological therapy can reduce COPD exacerbations, reduce the frequency and severity of the exacerbations, and improve health status and exercise tolerance. Each pharmacological treatment regimen should be individualized and guided by the severity of the symptoms, the risk of the exacerbations, side effects, comorbidities, drug availability and cost, and the patient's response, preference, and ability to use different drug delivery devices. So a lot of customization in treatment. COPD. Inhaler technique needs to be assessed on a regular basis. We do this every office visit in our practice. A lot of that depends upon how active the pharmacists are at teaching and coaching when the patient picks up their inhalers. Influenza vaccine decreases the incidence of lower respiratory tract infections. Pneumococcal vaccination decreases lower respiratory tract infections. Pulmonary rehab improves symptoms, quality of life, physical and emotional participation in everyday activities. In patients with severe resting chronic hypoxemia, long-term oxygen therapy improves survival. In patients with stable COPD and resting or exercise-induced moderate desaturations, long-term oxygen treatment should not be prescribed routinely. However, individual patient factors must be considered when evaluating the patient need for supplemental oxygen. So somebody that's more active and getting around more and desaturating with exercise, you're more likely to supplement than somebody that's not active and not desaturating because they're not active in the first place. In patients with severe chronic hypercapnia or CO2 retention and a history of hospitalization for acute respiratory failure, long-term non-invasive ventilation may decrease mortality and prevent rehospitalization. In select patients with advanced emphysema refractory to optimized medical care, surgical or bronchoscopic interventional treatments may be beneficial. We'll talk more about this at follow-up talk next week. Palliative approaches are effective in controlling symptoms in those with advanced COPD. As far, Ben, as what would be considered a moderate to severe desaturations, I don't know if there's any official standard. Most of us would consider a moderate desaturation something in the 86 to 90% range. Probably the 80 to 86% would be moderate and less than 80% would be severe. Obviously, depending upon the time that they're desaturating, it might affect things as well. For example, somebody sitting at 82 all night, while that might be a moderate level, would be considered more severe than somebody that falls as low as 78%, but only does so briefly during REM sleep. So I think that's why there's no hard, fast rules regarding what's a moderate versus a severe desaturation. Back to the slide, smoking cessation. Smoking cessation has the greatest capacity to influence the natural history of COPD. If effective resources and time are dedicated to smoking cessation, long-term quit success rates of up to 25% can be achieved. Brief strategies that'll help. You got to ask, systemically identify all tobacco users at every single visit. Implement an office-wide system that assures that for every single visit and every patient that smokes, tobacco use status is queried and documented. Strongly encourage all smokers to quit in a clear, strong, and personalized manner. Data clearly shows that when healthcare providers urge patients repeatedly to quit, they're more likely to try. You got to assess the willingness and rationale of the patient's desire to quit. Ask every tobacco user if she's willing to make a quit attempt at this time, meaning within the next 30 days. If the patient wants to quit, offer help. You can offer a quit plan, provide practical counseling, provide intra-treatment social support, and help the patient receive extra treatment social support. So we use a lot of smoking cessation support groups in our area. Recommend the use of pharmacotherapy when appropriate, and provide supplemental materials for the patient to bring home. There's a lot of 1-800 support lines. And arrange follow-up. So this is an important issue. This is not something you say, hey, why don't you consider quitting, and we'll discuss it when you come back on your annual visit next year. This is something worth scheduling a follow-up to see how the patient's doing and coax them along. Vaccination. Influenza vaccination can reduce serious illness, such as lower respiratory tract infections requiring hospitalization, i.e. pneumonia, and as well as death in COPD patients. Pneumococcal vaccines, including both the Prevnar 13 and the polysaccharide 23, are recommended for all patients over the age of 65. And when you look at those that are stable with COPD, influenza vaccine reduces the risk of serious injury or death. And the data behind the PCV13 and the polysaccharide vaccine are shown. What's interesting is the conjugated Prevnar 13 reduces bacteremia and serious pneumococcal disease, invasive pneumococcal disease in adults. This was also seen in earlier iterations of the same vaccine when used in young children. We looked at pharmacological therapy for treatment of COPD. We'll talk more about this at the next visit, but we have got beta agonists, which can be short or long acting. Some of the shorter acting ones would be things like albuterol or levoalbuterol. Some of the longer acting ones would include things like salmeterol or formoterol. We have anticholinergics, which can be short or long acting. You can have ipratropium bromide, which would be a short acting version. Tiotropium might be an example of a long-acting anticholinergic. We have combination drugs, which combined short-acting beta agonists with a short-acting anticholinergic, like would be seen in Combivent. And then we have combinations of long-acting beta agonists and long-acting anticholinergics, as is seen in medications like Anoro or Stiolto. We've got methylxanthines, things like theophylline, which are rarely used anymore. And then we have combination long-acting beta agonists as well as corticosteroids combined in one device. Several companies, Symbicort, Advair, Breo, and then the last class of medication, the phosphodiesterase 4 inhibitors. Roflumilast is the only one we have on the market in the United States and Canada currently. When we're using bronchodilators in stable COPD, it's important to realize that they're essential to symptom management and commonly reduce symptoms even when used on a regular basis. Regular and as needed use of short-acting beta agonists or short-acting muscarinic antagonists improve both the FEV1 as well as symptoms. Combinations of short-acting beta agonists and short-acting muscarinic agents are superior when you compare to either medication alone when you look at the FEV1 as well as symptom scores. So combined therapy is better than single therapy. Long-acting beta agonists and long-acting muscarinic antagonists significantly improve lung function, dyspnea, health status, and they reduce exacerbation rates. Long-acting muscarinic agents, antimuscarinic agents, have a greater effect on exacerbation reduction when you compare them to the beta agonists, and they decrease hospitalizations, which has not been seen with the long-acting beta agonists. Combination of a long-acting beta agonist along with a LAMA increases the FEV1 and reduces symptoms compared to monotherapy. These are all evidence, level A evidence. So combination therapy is better than monotherapy again. And combination therapy reduces exacerbation rates as compared to monotherapy or as compared to inhaled corticosteroids and a long-acting beta agonist. Tiotropium has been shown to improve the effectiveness in pulmonary rehabilitation and increasing exercise performance. And theophylline exerts a small bronchodilator effect in stable COPD, and that is associated with a modest amount of symptomatic benefit. Unfortunately, the smaller therapeutic window associated with theophylline generally discourages its use. When you look at anti-inflammatory therapy in stable COPD, when you looked at inhaled corticosteroids, an inhaled corticosteroid combined with a long-acting beta agonist is more effective than the individual components in improving lung function and health status, as well as reducing exacerbations in those with moderate to very severe COPD. Regular treatment with inhaled corticosteroid increases the risk of pneumonia, particularly in those with severe disease. Triple inhaled therapy of an inhaled corticosteroid, a LAMA and a LABA, increases lung function, symptoms, and health status, as well as reducing exacerbations when you compare it to inhaled corticosteroid and LABA dual therapy or LAMA therapy, LAMA monotherapy. When you look at oral steroids, long-term use of oral steroids has many side effects with no evidence of benefit. Phosphodiesterase 4 inhibitors in patients with chronic bronchitis and severe to very severe COPD and a history of exacerbations, the PDE4 inhibitor improves lung function and reduces moderate to severe exacerbations. It keeps them out of the hospitalization. It also improves lung function and decreasing exacerbations in patients who are already on a fixed dose LABA and inhaled steroid combination. When you look at antibiotics, long-term azithromycin and erythromycin reduces exacerbations over the course of a year. However, treatment with azithromycin is associated with an increased incidence of bacterial resistance and possibly hearing test impairments over the course of a year. Regular use of N-acetylcysteine and carbocysteine as a mucolytic or antioxidant reduces the risk of exacerbations in very select patient populations. And when you look at other anti-inflammatory agents such as simvastatin, it does not improve exacerbations in COPD patients. However, observational studies suggest that statins may have positive effects on some outcomes in patients with COPD who receive them for other cardiovascular and metabolic indications. Leukotriene modifiers have not been tested in COPD and are not commonly used. Those would be medications like Singulair. As far as the inhaled route, when a treatment is given by the inhaled route, the importance of education and training in the inhaler device technique can't be overemphasized. The choice of inhaler has to be individually tailored depending upon access, cost, as well as the patient ability and preference. It's essential to provide instruction and demonstrate proper technique when using an inhaler, and you need to recheck this at every visit. It's surprising to see what your patients are doing. I also handwrite this in on all prescriptions that the pharmacist should instruct the patient on use. Inhaler technique and adherence in therapy should be assessed before concluding that the current therapy is insufficient. So if they're not using the inhaler correctly or they're not using the inhaler at all, you can't say that the medication isn't working. When you look at other pharmacological treatments for COPD, we can use alpha-1 antitrypsin augmentation therapy, and it has been shown to slow the progression of emphysema in those with disease. There's no current evidence that antitussives play a role in COPD, and vasodilators don't improve outcomes and in fact may worsen oxygenation in patients with COPD. When you look at pulmonary rehab, it improves dyspnea, health status, and exercise tolerance in stable patients. It reduces hospitalizations in those that have had a recent exacerbation. When you look at education, education alone is not terribly effective. When you self-management interventions with communication with healthcare professionals improves health status and decreases hospitalizations and emergency department visits. Integrated care and telehealth, unfortunately, have not demonstrated benefit at this time. It should be noticed that those are not demonstrated to be benefit. However, there's a lot being done now. In many patients, the disease trajectory in COPD is marked by a gradual decline in health status and symptoms, punctuated by acute exacerbations that are associated with an increased risk of dying. Although mortality rates following hospitalizations for acute exacerbations from COPD are declining, they're still between 23 and 80%. As far as palliative care, opiates as well as neuromuscular electrical stimulation, oxygen, and fans blowing into the face can relieve breathlessness. In malnourished patients, nutritional supplements may improve respiratory muscle strength and overall health status. And fatigue can be improved by self-management, education, pulmonary rehab, nutritional support, and mind-body interventions. When we look at oxygen therapy in stable COPD. During exacerbations of COPD, non-invasive ventilation is the form of ventilation. It's the standard of care for decreasing morbidity and mortality in patients hospitalized with an acute exacerbation of COPD. So essentially acute on chronic respiratory failure. Long-term administration of oxygen increases survival in patients with severe chronic resting arterial hypoxemia, in patients with stable COPD and moderate resting or exercise-induced desaturations. Prescriptions of long-term oxygen does not lengthen the time to death or first hospitalization or provide sustained benefit in health status, long-term function, or lung function, or 6-minute walk distance. Resting oxygenation at sea level does not exclude development of hypoxemia when traveling by air or going to higher elevations. When you look at non-invasive positive pressure ventilation, it may improve hospitalization-free survival in select patients after a recent hospitalization, particularly in those with pronounced daytime hypercapnia with a PCO2 of over 52. How about other interventional therapies? Lung volume reduction surgery is a surgical procedure where they remove part of the lungs to reduce hyperinflation, making the respiratory muscles more effective pressure generators and improving their mechanical efficiency. Lung volume reduction therapy is generally only considered in those with severe upper lobe emphysema and low post-rehab exercise capacity. Bulectomy is used in those with it can decrease dyspnea and improve lung function in those with asymmetric large bullae. Transplantation is in selective patients with very severe COPD can improve quality of life and lung functional capacity. And then now there are interventional bronchoscopy procedures where they can insert valves or coils, and these have been shown to improve exercise tolerance, health status, and lung function at 6 to 12 months. And that's where we're going to stop for today. I see there's a question about the role of phosphodiesterase 4 inhibitors like Flumelast and side effects associated with weight loss. So I'm not sure what you mean by the specific phenotype, but in general, it's those with moderate to severe disease that are having exacerbations. And the real take-home point is it's been shown in these patients to cut down on exacerbations. So that's the goal. GI tolerance is one of the issues, nausea. So yes, not all the patients can tolerate it. And then there's another question. Does anyone see the use of Combivent Respimat? So I can't comment there. Combivent particularly in those with intermittent symptoms. In general, we move quicker to using longer-acting LAMAs or LABAs as opposed to the short-acting medications.
Well, that's great. Thank you very much, Mark. Rosalind, just to speak to your question about Combivent, you can certainly post that on our CSRT listserv, and I can help you with that if you want to fire me off an email about at cmccoy@csrt.com. The question was regarding the use of Combivent for COPD in Canada. So Rosalind was wondering if anyone's actually using it. I know the audio cut out a little bit, so you may have missed her question. We're a little bit over time, so if you have any questions that you'd like to send to me, I can forward them on to Mark to address next week. Again, my email is cmccoy@csrt.com. Everyone who participated today will receive a link to receive their certificate. And I want to extend a huge thank you to Mark and to sleepedu.org. Both Mark and sleepedu.org have been huge supporters of the CSRT. And if you're not familiar with the courses available through Sleep EDU, they have a really large variety of them. They're not just related to sleep. I've gotten the privilege of being able to review each of them, and they have such a variety that would be of interest to RTs working in sleep, critical care, admin, community care, chronic care, acute care. So it's really worth taking a visit at sleepedu.org. couple of questions asking for my email. I'm Carolyn McCoy. My email is cmccoy@csrt.ca. Thank you very much, everybody. This recording will be made available by the end of the week, and I look forward to seeing you all again next week.
Thanks, guys.